Long bones feature a hollow, cylindrical shaft. This diaphysis is capped by expanded epiphyses. The metaphysis is the locus for elongation.
Ribs are classified as flat bones, despite their tubular appearance. The clavicle is a long bone, with an S-shaped curvature.
The clavicle lacks a classic medullary cavity. It is the first to ossify, but among the last to complete, while its medial end forms through endochondral ossification.
Bone is organized into dense outer compact bone and an inner network of spongy bone. Osteocytes reside in lacunae, obtaining nutrients through direct diffusion.
Compact bone is organized into osteons, concentric lamellae with alternating collagen fibers. At the center is a Haversian canal, housing a neurovascular bundle. Volkmann's canals directly perforate the lamellar layers. Interstitial lamellae fill the spaces between active osteons. The outer fibrous layer of periosteum consists of dense connective tissue. The inner osteogenic layer is highly cellular. Periosteum is anchored by Sharpie's fibers. All bone cavities are lined by endosteum, the organic phase or osteoid by osteoblasts.
This organic phase provides bone with its tensile strength, elasticity, and resistance to fracture. Crystalline mineral salts, primarily calcium phosphate, provide Osteoblasts are active bone-building cells. They are cuboidal with a prominent Golgi complex. They secrete type 1 collagen and initialization. They also regulate osteoclastic bone resorption.
Osteoclasts are massive, multinucleated cells. They feature a specialized ruffled membrane. This border secretes acid and cathin. This process resorbs the mineralized bone matrix.
Osteocytes are the most abundant cells in bone. They feature dozens of long, branching processes. They secrete key products like sclerostin and FG3. This network acts as the primary mechanosensory system. Movement operates through kinematic chains. In an open chain, the foot moves freely. In a closed chain, the foot is fixed to a surface. If one joint is restricted, others compensate. This leads to stress and instability.
Joint motion involves osteo- and arthrokinematics. Here, the convex humerus glides downward, while the shaft moves upward.
In a concave on convex motion, the surface glides in the same direction as the bone. Muscles generate force by pulling, working in antagonistic pairs to create rotation. Skeletal joints act as fulcrums, F. Muscle contraction provides the input effort force, E. The combined mass constitutes the resistance. These systems are classified into 3 distinct categories. The atlanto-occipital joint acts as a first-class lever. Here, the fulcrum lies between the effort and the resistance. This system provides balance and stability for the head. The ankle joint acts as a second-class lever. Here, resistance lies between the fulcrum and effort. This builds a mechanical advantage greater than 1, maximizing power to lift your entire body weight. Third-class levers are the most common in the human body. Here, the effort is applied between the fulcrum and resistance. This setup maximizes speed and range of motion, perfect for quick appendicular movements. Third-class levers prioritize speed in the human skeleton. This is governed by the lever equation. In static hip flexion, a 150 Newton force through the center of mass. This generates a torque of 75 Newton meters. To maintain this position, the hip flexor muscles must torque. This requires a force of 700 newtons. However, a minor contraction translates into a rapid displacement of the foot, essential for kicking.
The femur is optimized to withstand multi-axial loads. Its neck in adulthood. The calcar femur reinforces the medial side. Trabecular patterns organized to distribute these forces.
Primary trabeculae support axial loads. Tensile bands resist bending stresses. These tracts mature by age 18. This outlines Ward's triangle. It is highly susceptible to fracture.
Clinical evaluation uses the Singh index, rating density as these lines disappear. The humerus features a spherical proximal head and a cylindrical diaphysis.
Due to its structure, the humerus is susceptible to specific injuries. In children, supraconjuries. Displacement can endanger the median nerve or the radial artery. Supracondylar process, connected by Struthers ligament, creates a tunnel, entrapping nerve and artery. The tibia is the massive weight-bearing bone. Its proximal plateau articulates with the femur. Distally, it forms the ankle joint. In children, the tubercle contains an apophysis. Here, the patellar tendon inserts. Repetitive loading can cause Osgood-Schlatter disease. Growth plate fractures are classified using the Salter-Harris system.
The clavicle is a doubly curved long bone. It articulates medially at the sternoclavicular joint. Ligaments anchor it to the sternum and stabilized by the coracoclavicular joint.
The clavicle's shaft is divided into a medial 2/3 and a lateral 1/3. The inferior surface contains the subclavian groove. The lateral third anchors the deltoid and trapezius muscles. Clavicle fractures account for up to 10% of all human fractures. Group 1 occurs in the middle third, Group 2 in the distal, and Group 3 in the proximal. Mears classification predicts non-union risk in distal fractures.
Anatomical variations include sex differences. 2 to 3% have an anomalous muscle. The clavicle may be absent in cleidocranial dysostosis. This is a rare congenital disorder.
Bone modeling and remodeling are regulated by complex, cell-to-cell signaling pathways that balance bone resorption and bone formation. LRP5/6 receptors. This inactivates the GSK3 complex. Cytoplasmic beta-catenin now accumulates and enters the nucleus to promote bone formation. Consequently, beta-catenin accumulates and translocates into the nucleus, where it binds to TCF transcription factors, shifting the balance away from resorption. To prevent excessive bone formation, osteocytes secrete antagonists, binds to LRP5/6, blocking ligands. This leads to beta-catenin degradation, which downregulates osteoblast activity.
PTH stimulates bone formation by reactivating the WNT pathway. Antibodies like romosozumab promote bone deposition.
RANKL is produced by osteoblasts and osteocytes. It binds to its receptor, RANK, on preosteoclasts. This cascade drives the fusion of preosteoclasts, promoting their bone-resorbing activity. Osteoblasts secrete OPG, a soluble decoy receptor. A high RANKL to OPG ratio accelerates bone loss, while a low ratio promotes bone preservation.
Monoclonal antibodies mimic OPG. They bind to RANKL to suppress bone resorption, targeting metabolic bone diseases. These pathways are summarized.
RANKL binds to the RANK receptor. This recruits TRAF6 NF-kappa B. OPG acts as a decoy receptor. Denosumab blocks RANKL to stop bone loss.
Bone marrow is a dynamic tissue. It shifts between red and yellow types. Red marrow is highly vascularized, composed of water, lipids, and proteins. On T1 MRI, it shows cells. Widespread at birth, it later restricts primarily to
Yellow bone marrow serves as a key energy reservoir. It is composed of 80 lipids and fills the long bones. On T1 MRI scans, it exhibits signal intensity. It replaces red marrow during skeletal growth. At birth, red marrow occupies the entire skeleton. This conversion follows a specific directional pattern, diaphysis to metaphysis.
At birth, cartilaginous regions rapidly fill with yellow marrow. This distal to proximal conversion preserves red marrow in the axial skeleton. Fatty infiltration first, converting to yellow marrow. During high demand, long inactive yellow marrow reverts to red marrow. This reconversion starts in the axial skeleton and proximal metaphysis.
Primary bone healing requires absolute stability. In gaps under 0.01 millimeters, cutting cones form, a tunnel for repair. This allows direct Haversian remodeling.
Following closely behind the osteoclasts, a vascular bud and osteoprogenitor cells invade the newly formed tunnel. The osteoprogenitor cells differentiate into osteoblasts and lay down concentric lamellae. Physical trauma ruptures blood vessels, causing internal bleeding and a fracture hematoma. The resulting hypoxia, cytokines and growth factors recruit neutrophils and macrophages to debride the site. Fibrovascular tissue invades the clot. Stem cells proliferate and differentiate. They form chondroblasts here and osteoblasts at the periphery. This soft callus forms a flexible bridge. During hard callus formation, chondrocytes undergo hypertrophy and calcify their surrounding matrix. Invading blood vessels carry osteoprogenitor cells, which differentiate into osteoblasts. During remodeling, disorganized woven bone is replaced. Regulated by Wolff's law, bone adapts to the loads it experiences. This creates a highly organized, stronger structure. The bone is fully restored. Wolff's law states that bone adapts to stress. Osteoclasts resorb the unaligned bone, while osteoblasts lay down new bone along workload lines. This process restores vascularity and structure. Bone grafts promote healing through three mechanisms. Osteoconduction provides a physical scaffold for growth, stimulates stem cells to differentiate, and osteogenesis directly synthesizes new bone. This process is mediated by creeping substitution. Osteoclasts excavate channels through the necrotic matrix. This is coupled with the simultaneous deposition of new bone. Host microvessels and osteoprogenitor cells invade these channels. In dense cortical grafts, creeping substitution is a slow process. Remain weak as resorption outpaces deposition. Cancellous bone grafts integrate rapidly. Their porous structure facilitates rapid vascularization, osteorized bone grafts, and quick replacement, allowing direct bone healing without temporary weakening. Paget's disease disrupts bone dynamics. Large, hyperactive osteoclasts drive this pathology. Mutations in SQSTM1 trigger constant signaling.
Stage 1 is the osteolytic phase. Intense osteoclastic resorption dominates. On X-rays, it shows a blade of grass sign. Stage 2 is the mixed phase, with chaotic bone deposition. Poggetic bones are dense yet brittle. Bowing diagnosis shows isolated elevations in alkaline phosphatase induces local hypervascularity. Arteriovenous shunts can lead to heart failure.
Intense osteoclastic resorption dominates. Advancing lytic wedges form a candle flame sign. Rapid osteoblastic deposition creates woven bone. This leaves behind chaotic cement lines. Osteoblastic activity becomes dominant. This architecture resembles a jigsaw puzzle. Chronic overactivity can trigger malignant transformation. This leads to osteosarcoma.
Achondroplasia is caused by a genetic mutation in gene. This continuously activates the receptor proliferation. This leads to restricted bone elongation and short-limbed dwarfism.
Rickets prevents proper bone mineralization. Unmineralized osteoid matrix accumulates. Growth plates widen and flare out. Weight-bearing causes progressive bowing. Salter-Harris fractures are traumatic injuries. They involve or cross the epiphyseal plate. Improper management can lead to premature fusion.
Defects can lead to limb anomalies. Polymelia is duplication. It is the duplication of a whole limb. Syndactyly is conjoining. Simple involves soft tissue. Complex involves bony union. Polydactyly is the presence of extra digits. It can be preaxial, postaxial, or central. A triphalangeal thumb has 3 phalanges, giving it a finger-like appearance.
Long bones are dynamic structures. They resist multiaxial loads, balancing resorption and deposition, coordinated by complex pathways. Disruptions lead to pathologies.